So when we talk about mitral stenosis, what we're referring to is a narrowing of the mitral valve. The mitral valve is not opening properly. Uh, just when we talk about stenosis of anything, it's a narrowing. Stenosis is a narrowing. So you have to first of all have an idea what the normal mitral valve looks like and the normal mitral valve area. Remember, we always stress you have to know what normal structures and function looks like. So when something is abnormal, you can readily uh, identify it. And the same thing goes for mitral stenosis or the mitral valve. So you have to know what the normal mitral valve looks like. So when the mitral valve is stenosed or narrowed, you can readily identify that. The normal mitral valve area is 4 to 5 centimeters squared. Um, you know, when if you look at the mitral valve in the short axis view, it looks like a fish mouth. Um, and then if you see the mitral valve in the parasternal long axis view, you can see where the anterior leaflet separates from the posterior leaflet. So develop a habit of looking at the different valves and the different views so you know exactly what they look like. The mitral stenosis is extremely important because when when someone has mitral valve, rheumatic heart disease, the mitral valve is commonly affected and they will develop mitral stenosis after a few years. So for that reason, it's very important. So the most common cause for mitral stenosis is rheumatic heart disease. So what usually happens, the child will have rheumatic fever, age 5 to 15, and then 5 to 10, 15 years later, they will develop or they can develop mitral stenosis. The next common cause, I would say, is senile degeneration, age-related mitral stenosis. So that is the older one gets, the valves, not only the mitral valve, but the valves degenerate, and you get thickening, calcification, and restriction of movement. You must have seen mitral annular calcification in older patients, and that can also extend to the valve and cause mitral stenosis. Infective endocarditis can essentially obstruct the mitral valve and give rise to mitral stenosis. And then tumor, you must have seen the common uh, myxoma that obstruct the mitral valve. So it doesn't. It's not going to cause the classic mitral stenosis, but it's going to obstruct the valve, and it presents like mitral stenosis. Signs and symptoms of mitral stenosis. So uh, when the heart is malfunctioning, you're going to get a series of signs and symptoms that is common to all heart disease. There are going to be a few that are more specific to mitral stenosis. Uh, Shortness of breath, any type of cardiac pathology going to give you shortness of breath. You can have exertional shortness of breath, that shortness of breath when you exert yourself. PND, patient goes to bed, wake up a few hours later with shortness of breath. Orthopnea, they cannot lie flat. Palpitations because of either tachycardia as a compensatory mechanism, or they might develop premature atrial ventricular beats or some other type of arrhythmia, so palpitation, chest pains, hemoptysis, which is more specific to mitral stenosis because blood cannot get out of the left atrium. It backs up into the pulmonary vein and extends into the lungs, destroying the capillaries in the lungs. So you so-called have bleeding into the lungs then. And so when the patient would commonly cough up blood. Okay, so hemoptysis is more specific. Thromboembolism is probably more specific to mitral stenosis as well, because blood cannot get out of the left atrium. The left atrium is not, if the patients commonly develop atrial fibrillation with mitral stenosis because the left atrium enlarge, and then that sets up atrial fibrillation. And then when the patient develops atrial fibrillation, the atrium is not contracting and blood stagnates, and you get thrombus or blood clots into the left atrial appendage. Those clots can break off and embolize. So thromboembolism is probably more specific to mitral stenosis. And you can get ascites, and ascites comes from, these patients commonly develop pulmonary hypertension for the same reason as they develop hemoptysis. Increased pressure into the left atrium, backs up into the pulmonary veins, back up into the pulmonary system. You develop pulmonary hypertension, and that backs right up into the RV, the RA, and into the liver. And these patients can develop ascites, hepatomegaly, that is painful hepatomegaly. The liver is enlarged. So hepatomegaly means enlargement of the liver. The liver is enlarged and tender. Okay, leg edema for the same reason. And the classic murmur for mitral stenosis, because the mitral valve opens in diastole, so you expect to get the abnormal sound or murmur in diastole, but it's a diastolic rumble, so it's different from aortic insufficiency in that the sound you're going to get is a rumble. With aortic insufficiency or aortic regurgitation, you get a blowing diastolic murmur, but with mitral stenosis, you get what we call a diastolic rumble. Specific to the mitral valve, to mitral stenosis, you're going to get what we call an opening snap. And that is because the mitral valve is thickened, it's calcified, and when in diastole, when the mitral valve should open readily, when it's opening, it makes a sound. That sound is called the opening snap. It's a diastolic sound. Okay, and for those of you who delve more into mitral stenosis, we talk about a S2 opening snap interval. That is, S2 is when the aortic valve and the pulmonic valve close, and when the valve close, they make a sound. And if you can time the interval from the closure of the aortic valve to this opening snap, it can give you an idea of the severity of the mitral stenosis. The shorter the S2 opening snap interval, the more severe the mitral stenosis. But that's for people who for the physicians in the group who need to know this. All right, so these are the features of mitral stenosis. Again, the parasternal long axis view, you need to know what a normal echo looks like. So when you have an abnormal echo, you can readily identify that. So let's point out a few things. All right, so this is our septum, our ventricular septum. So aortic valve. This is a nice aortic valve. You see, it's thin. This is a diastolic frame because the aortic valve is closed, and when it closes, you can see it closed with a very thin closure line. That's what you want to see. This is the anterior mitral leaflet. Posterior leaflet is down there. You can readily see, remember, the markings on the side usually 1 centimeter separation. So these markings are usually 1 centimeter in separation. You can readily see that the left atrium is large. The left atrium is huge. But look at the anterior mitral leaflet. If you've been looking at a lot of echoes, you know that this anterior mitral leaflet is abnormal. And we talk about an acoustic configuration. So those of you who know what an acoustic look like, the anterior leaflet assumes what we call the acoustic configuration, which is it's almost pathognomonic of rheumatic mitral stenosis. It almost always suggests rheumatic mitral stenosis. So the so-called acoustic configuration of the anterior mitral leaflet. Okay, so it looks like an acoustic. Okay, the anterior leaflet. Okay, it's thickened. Okay, thickened. So when when you start doing your echo, this is going to be readily apparent. So if you see this, then you're going to do additional measures to further identify and quantify the severity of the mitral stenosis. All right. All right, let's. So you have to be able to. So this is the anterior mitral leaflet. Talk about the acoustic configuration of the anterior mitral leaflet. Okay. The left atrium. So get into the habit of measuring your structures. We always talk about that. And you can see that that left atrium is huge. The upper limit of measurement of the left atrium is 4 centimeters. So this measures 5.66, which is huge. And then when you look at the short axis, you can see that the mitral valve is thickened. It has this fish mouth configuration. And then when you look at your apical four-chamber view, okay, you can see that this is a diastolic frame, and the mitral valve should be fully open. And you can see that it's thickened and it's not opening well. You can see that the left atrium is also enlarged. Okay. Okay, so that is mitral stenosis. Okay. First, you have to be able to identify it. You have to know the different cause. A very common cause, as we mentioned, is rheumatic heart disease. Rheumatic mitral stenosis is classic because you have the acoustic configuration of the anterior mitral leaflet. It's thickened. Senile degeneration is not a very common cause. But there are other things that can give rise to mitral stenosis. It's not very common, but you need to know them. So having identified that the patient have mitral stenosis, you have to quantify it because it depends on whether it's mild, moderate, or severe. The treatment differs. Okay, so the methods that we use to identify the methods we use to grade the severity of the mitral stenosis, we can use something we call the pressure half time. We can to get the area. We can use the continuity equation to get the area. We can use just do planimetry method, and we can do gradients. So we're going to go over all of that. Okay, so we can use the gradient to assess the severity of the the mitral stenosis. So when we do gradient, we have to do CW, continuous wave Doppler. So if you're going to use the gradient to assess mitral stenosis, you have to use CW, continuous wave Doppler. If the patient is in sinus rhythm, you're going to use at least 3 mitral inflow envelopes. If the patient's in atrial fibrillation, you use a minimum of 5 cycles. Okay? All right? And then you average them. If the patient's in sinus rhythm, however, you're going to use a minimum of 3. And for atrial fibrillation or any abnormal rhythm, you use at least 5 cycles. Things that can affect using the gradient method to assess mitral stenosis. Patients have significant mitral regurgitation. If the heart rate, if the heart rate is very high, that can affect it, and cardiac output. So if you just sit back and try and understand what we're doing. So remember, the gradient is the pressure difference. So when the blood is in the left atrium, it's going to force its way to go through this stenosed mitral valve into the left ventricle, and it's going to create a certain gradient, a pressure difference between the left atrium and the left ventricle. But this is in diastole. If you increase the amount of blood into the left atrium, then it's going to affect the gradient. So that is why we say if the patients have significant mitral regurgitation, you're going to force a lot of blood going backwards into the left atrium. So what's going to come across the mitral valve, forward flow across the mitral valve, is going to increase. So if the patient has significant mitral stenosis, you shouldn't use the gradient method to assess the mitral stenosis. Also, if the patient is in a tachycardia, if the heart rate is very rapid, that's going to automatically increase the gradient across the mitral valve. And if the cardiac output is low, it's going to reduce the gradient. So in this situation, you probably shouldn't use the gradient method. And when we do gradient, all we do, you guys are familiar with the mitral inflow pattern with your E and your A velocity, or E and your A wave. All you do, you to get the gradient, you just planimetry. You do planimetry of the envelope. You do planimetry of the envelope, the mitral inflow envelope. But you need to use CW. We call it mild mitral stenosis if the gradient is less than 5 millimeters mercury. And if it's greater than 10 millimeters mercury, we call it severe mitral stenosis. Anything that falls in between is moderate. So again, the gradient across the mitral valve, all you do is the mitral inflow envelope, CW, however, you do planimetry. The machine, you can just use it to do planimetry of the mitral inflow envelope. If it's less than 5 millimeters mercury, it's mild. If it's more than 10, then it's severe. And this is how it's done. Okay, so 4-chamber view is on top. Your cursor is across the mitral valve. Sample volume is at the mitral valve. And this patient looked like he's in atrial fibrillation. So this is your mitral inflow, 1, 2, and then you're going to have 3 and go on. So when the patient's in atrial fibrillation, however, all the envelopes are going to be different. Okay, all the mitral inflow envelopes is going to look different. So that is why we say you have to use a minimum of 5 of them and average them. Okay, so if you get 5 for this one, 10 for this one, and so on for that, you just add them up and divide it by, if you're going to use 5, you add them up and divide it by 5, and you will get the average gradient. So that's what we mean, okay? And again, mild mitral stenosis means the gradient is less than 5 millimeters mercury, and severe means it's more than 10 millimeters mercury. All right? So get in the habit of, looking to see if there's abnormal rhythm. All right, let's move on. Okay, so you can also use the planimetry method. And when we talk about planimetry, what we mean is in the short axis view, when the mitral valve opens, you can trace the border of the opening, and the computer in the machine will give you an area which is the mitral valve area. However, you have to be careful when you're using this method, because the opening of the mitral valve, we say it looks like a fish mouth, but it's also funnel shape. Okay, it is a funnel shape. So in a funnel, you're going to have a very narrow area and a very wide area. So you have to make sure that you get the narrowest area in that funnel, and that's what you want to planimet. That's what you want to do your planimetry. So the planimetry is a direct tracking or tracing of the mitral orifice from the parasternal short axis view. You're going to scan from apex to base to ensure that the area is measured at the leaflet tips, because it's funnel shaped. And you're going to zoom. You always, when you're doing any measurements, zoom, because you're going to make the error less. Okay. So, and this is what, so this is a funnel. So there's going to be a very narrow restricted area and a much wider area. You want to find the narrowest area, and this is what you're going to, where you're going to do your planimetry. So the mitral valve is shaped like a cone. Okay. So in planimetry, you have to do you have to planimeter the planimetry of the smallest area. Okay. And this sort of highlights what I'm saying. So if you don't do planimetry of the smallest area, and you say, for instance, do this one, then it's not going to be the true area. All right. So, all right. Another method that we use is the so-called pressure half-time method. Okay. And the pressure half-time, so we've been talking about pressure half-time and deceleration time forever. So the pressure half-time, when we talk about pressure half-time, it's the time it takes for the pressure to fall to 1/2. So that's basic. Okay, pressure half-time, it's a time, and it's a time that it takes the pressure to fall to 1/2. And just to give you, this is just for you to better understand what we mean by pressure half-time, so you don't try to understand it in a vacuum. So if we have pressure on the vertical axis, and we have time on the horizontal axis. So if, say, the pressure across the mitral valve is, say, P1, so it's say P1. Okay. So if the pressure falls from P1 to half its value, okay, the pressure falls from P1 to half its value. We want to find the time that it takes to do this, to make this fall. Okay? It's the time it takes to do this fall. And if you if you have a line like that, sorry about that. So if you come down like that, all you have to do is come across and then come down, and it will give you the time. Okay, pressure half time. So if you have a graph, you can easily figure it out. But a lot of time you don't have a graph. Okay, you don't have a graph. So it's either you're going to work it out or whatever. But the computer can do that. So remember that pressure and velocity is related. Okay, pressure and velocity is related. So what the computer is going to do, it's going to look at the pressure at this point, and that pressure is equal to 4v squared. Okay. Then at half the pressure, it's gonna find out what the velocity is, and then it's gonna look and see what time it's gonna take for the velocity to reach to the point corresponding to the pressure half time. But again, you don't have to understand. Well, if you can understand the method, fine. But anyway, it is the time it takes for the pressure to fall to 1/2. And it will give you, it's an assessment of the area of the mitral valve. The smaller the pressure half time, okay, then the larger the area. The greater the pressure half time, the smaller the area. So when the area is very tiny, it takes a longer time for the pressure to fall to 1/2. Okay, that's basically what it's saying. And the formula that is derived is the mitral valve area is equal to 220 divided by the pressure half time. Okay, so if you don't understand anything I said before, this is what you need to memorize. Mitral valve area is equal to 220 divided by the pressure half time. Okay, so the pressure half time is a time. And again, that time it's a time for the pressure to fall to 1/2. And if you just think about it, the narrower the valve, the smaller the valve area, it's going to take a much longer time for the pressure to fall to 1/2. All right. So again, when you do your E and your A velocity, so your E and your A velocity, so you get um, these type of thing. Again, what you want to do to get your pressure half time, you're gonna put your cursor and you're gonna just trace the slope. It's a slope. Okay, you're gonna trace the slope of the E wave, the slope of the E wave. So that's all you need to do when you're doing your study. So you should recognize this as the mitral inflow pattern with your E and your A wave. Okay, so if it looks like this, you don't want to trace from this point downwards. You want to trace where it's it's fairly consistent right there. Okay, and then the computer will give you, if it give you the deceleration time, you can find out what the pressure half time. Again, the pressure half time is 0.29 times the deceleration time. We have said that over and over. Okay, so pressure half, so the mitral valve area is 220 divided by the pressure half time. All right, so this is what you do in actuality. So the mitral, if your apical four-chamber view, the cursor is across the mitral valve, and you're going to get these mitral inflow pattern. Okay, if the patient is in atrial fibrillation, you need a minimum of 5 envelopes. If the patient is in sinus rhythm, then you need a minimum of 3. Okay, and then, so what you're going to do, you just put your line down so you can see this is, you just trace it down. Okay, and you'll get a time. Okay, so and whatever time you get, you're going to divide 220 by the time, and it will give you the mitral valve area. Okay, that's the pressure half time method. Okay, so 220 divided by pressure half time. You have to use C doubler. You're going to trace the slope, and you'll get the pressure half time. You divide 220 by the pressure half time, and you'll get the mitral valve area. You can also use the continuity equation. Of course, if you remember what the continuity equation states, the flow across any of the valves should be the same unless you have significant regurgitation. All right, so the flow across the mitral valve equals the flow across the aortic valve. Okay, the flow across any valve is the cross-sectional area times the time velocity integral. If you're going to use the mitral valve, then the mitral valve area times the TVI should equal to the flow across either the left ventricular flow tract or the aortic valve. So you can use a left ventricular flow tract because we measure diameter in all our studies, so you can get the cross-sectional area across the left ventricular flow tract, and you can measure the TVI across the left ventricular flow tract. So you will know the flow across the left ventricular flow tract, and that's going to equal to the flow across the mitral valve, which is equal to the mitral valve area. This is what we don't know. This is what we're trying to find, the mitral valve area. But the mitral valve area times the TVI across the mitral valve is going to equal to the flow across the left ventricular flow tract. Just rearranging the equation, you can solve for the mitral valve area by just knowing the left ventricular flow tract area. It's circular, so the area of the left ventricular flow tract is pi r squared. We always get the diameter in the parasternal long axis view, so you just divide the diameter by 2 and you get the radius, and you plug it in the equation. The TVI across the left ventricular flow tract, we commonly do that, and the TVI across the mitral valve, you just do planimetry. So your cursor is going to be at the mitral annular plane, where the mitral valve is, and then you open the mitral valve, and then you're going to get your mitral inflow envelope, and you just do planimetry and to give you the TVI. Okay, so you plug those in the equation, and you again you measure diameter of the left ventricular flow tract. You measure the TVI across the left ventricular flow tract and the TVI across the mitral valve, and this is how it's actually done. Okay, well, we'll see if so basically what. Okay, let me just draw, since we didn't have it. All right, so when you do your mitral inflow, you get your E. And then your A velocity. Okay. So what I'm saying, to get the TVI across the mitral valve, you just do planimetry. You plane the outer border. So you're gonna trace the outer border just like you do. Okay. And the computer will give you, anyway, this is supposed to come straight on. The computer will give you the TVI. Okay, so you're supposed to have your apical 4-chamber view. You're going to put the cursor at the mitral annular plane, and I'll go over that because that's important to understand. Okay. Right. You can also use the PISA method to evaluate the mitral valve area. So we know we can use it in regurgitation, but you can also use it in stenosis as well. Using the same concept that the flow. So when you have mitral stenosis, okay, when you have mitral stenosis, blood is going to force its way across the mitral valve, okay? So, and it's going to set up a series of concentric shells, okay, what we call the PISA over there, okay? And that's going to equal to the flow across the mitral valve when it's stenosed. So the flow again is equal to the area times velocity, and in this case we use the peak velocity, and that's going to equal to the flow at PISA. And we just rearrange the equation, and you can solve for the mitral valve area. The only difference is that if you look at the mitral valve, when we use the PISA method, okay, when we use the PISA method, we assume that the valve plane is flat. We assume that the valve plane is flat, okay, and then you have the hemispheric shells on top, okay. So this is what we assume, but in actuality, when the mitral valve closes, it's actually like this. So it is not flat. It is not flat. So if it's flat, it would have been like this. So there's an angle right there, okay, and we call this angle theta. Okay, so it's not flat. So this angle theta is what we call the opening angle of the mitral leaflets. So you have to have a correctional factor when you use the pizza method for mitral stenosis. So the correctional factor is this angle, the opening angle, divided by 180, because we assume that the opening angle is 0. Okay, so if you put 0 there, you get this correction factor is 0. Okay, but if the mitral valve opens like this, there's a opening angle. If this opening angle is 30 degrees, then the correction factor is 30 over 180. Okay, and then you make your correction. We assume the correction angle is 0 up here, but in actuality, there's always a value to this correctional factor. So you have to add it to you have to put it in. So if it's 150, then you're going to put in 150. Okay. All right. All right. So let's move right along. All right. So when you're assessing the mitral valve, of course, you need to know the methods that you're gonna use to give you an idea of the area of the mitral valve. We talk about the gradient method, and that divides the mild, moderate, and severe. Mild is less than 5, severe is greater than 10. We talk about the pressure half-time method, where we use 220 divided by the pressure half-time. And we talk about the continuity equation method, where we use the fact that the flow across the valves are similar, and flow is equal to area times TVI. And then we talk about the pizza method. It's not used a lot, but you need to know that it exists, and you need to know about the opening angle. But if you're going to send a patient, or you're not going to send the patient for any treatment, you need to know why. You need to know what you're going to look for, what you need to look for. So the things that we look for when someone presents with mitral stenosis is the valve thickening. How thickened this valve is, how calcified the valve is. What about the mobility of the valve? Okay, so those are very important things. The thickness of the valve, calcification of the valve, the mobility of the valve, how mobile the valves are. And then the subvalvular apparatus, so the cords and stuff like that. So the cords sometimes are very thickened, short, and calcified. Okay, so those are important things that you're going to look for. And those are what you find is going to tell you whether the valve can be repaired or it needs replacement. So it depends on what you find. It's going to tell you whether the valve can be repaired or it needs to be replaced. Again, you look at the valve. We talk about thickness of the valve, calcification of the valve, the mobility, how mobile the valves are, and then the subvalvular apparatus, that is all the structures below the valve, how they look. Okay, again, acoustic configuration of the anterior mitral leaflet suggests mitral stenosis. So you tell you the etiology, tell you what caused the mitral stenosis. Okay, more than likely rheumatic. And so what I just told you, we can put that into a score to tell us whether the patient is feasible for mitral valve repair or mitral valve replacement. If the patients do much better if you repair the mitral valve as opposed to replacing the mitral valve. Okay, so patients do much better if you repair the mitral valve. Okay, so patient will do much better if you repair the mitral valve as opposed to replacing the mitral valve. So that is why it's important to look at these features and see if the patient would benefit from repair as opposed to replacement. And the scoring system is called the Wilkins scoring system. Okay, and again, you look at the mobility of the valve, the thickness of the valve, calcification of the valve, and then you look at the subvalvular apparatus, see if it's thickened and calcified. And you're going to give scores from 1 to 4. Okay, each of these features you're going to give a score of 1 to 4. 1 means that it's almost normal. Okay, so for a mobility of 1, it's highly mobile with only the leaflet tips being restricted. And then for thickening, the leaflets are near normal in thickness. That means they're less than 5 millimeters. Calcification, you might just have a single area of increased echo brightness, so that's not much calcification. And then for subvalvular thickening, minimal thickening just below the leaflet tips. So if a patient presents with all grade 1, then the total score, you're going to add them up, of course, the total score would be 4 because each feature would get 1. Mobility 1, thickness 1, calcification 1, subvalvular thickening 1. So this would be a very good candidate for mitral valve repair if they have a score of 4. So a score of 8 or less would suggest that the patient would benefit from repair as opposed to replacement. If you have a patient who have all 4s, so for mobility, they have no or minimal forward movement of the leaflets in diastole, so it's restricted, it's not moving. And then for thickening, considerable thickening of all the leaflets, your measure it is more than 8 millimeters. And then for calcification, extensive brightness throughout much of the leaflet tissue, extensive calcification. And then you look at the subvalvular apparatus, that is all the areas below the mitral leaflet. With the stuff that's below the mitral leaflet is the chordate tendineae. So if you have extensive thickening and shortening of all chordal structures, extending down to the papillary muscle, then you give them 4. So if they have all the features, if they have 4, so 4, 4, 4, 4, they have a total score of 16. All right, so when you add up everything, so you add up the scores, and if they have a score of 16, then they're not a candidate for mitral valve repair. They're going to have to get the valve replaced completely. Okay, so the Wilkins score help us to determine whether the patient can go for mitral valve repair or replacement. Another feature that we use is if the patient has significant mitral regurgitation. If the patient has significant mitral regurgitation, then you have to replace the valve. Repair is, well, I mean, if with commissurotomy, so we have different type of repair. Okay, we have different type of repair. So if the patient have a score of 4 and they don't have significant mitral regurgitation, we can do what you call a balloon valvotomy So we can do this percutaneously. We can go through the femoral, um, go through the femoral vein, okay? Go through the femoral vein, go up to the right side of the heart, puncture the atrial septum, and go across the mitral valve, use a balloon, and just open the mitral valve. However, if the patient has significant mitral regurgitation, we can't do that. We have to do open repair of the valve, okay? And probably put a ring in as well. All right, so we went over all of this to come to this, okay? The classification of mitral stenosis. So the patient will have severe mitral stenosis. If you use whatever method, you might use the pressure half-time method, you might use the continuity equation method, or the pizza method. If the valve area is less than 1 centimeter squared, the mitral stenosis is severe. If the mean gradient, so what we use is the mean gradient. Again, apical 4-chamber view, continuous wave Doppler. if the if the mean gradient is greater than 10 millimeters mercury, it suggests that the mitral stenosis is severe. Remember what we say, when a patient have mitral stenosis, they're going to be a backup of the blood and pressure, in the pulmonary vein, the lung system, in the pulmonary trunk. So the patient will commonly develop pulmonary hypertension. So if the pulmonary pressure is greater than 50 millimeters mercury, it also suggests severe mitral stenosis. And for mild, the valve area is greater than 1.5 centimeters squared, suggests mild mitral stenosis. The mean gradient less than 5 millimeters mercury, and then pulmonary arterial pressure less than 30, suggests mild mitral stenosis. Anything that falls in between these two extremes is moderate. You have to assume, this table is only valid if the heart rate is between 60 and 80 beats per minute and the patient is in sinus rhythm. Again, remember, the faster the heartbeat, the faster the heart rate. If the patient has tachycardia, it's going to falsely increase the gradient. So you can't use, you cannot, if you're going to use the gradient, you have to, you can't use the gradient. The best thing to do is using the continuity equation. And then if the patient is not in sinus rhythm, say atrial fibrillation, if you're going to use something like the pressure half-time method, you have to use at least 5 cycles. The more cycles you use, you can reduce the error, so to speak. So, but you need to know this table, all right? And we're gonna stop here. You need to revise mitral stenosis. It's very common, and you need to know it inside out.